Okay, we're recording. All right, so at this point, I'm going to put everybody on mute and turn it over to Chrstine Blidy to get started with our webinar.
All right, well, welcome everyone. Thank you so much for joining us this afternoon, particularly during your lunch hour. Very excited to talk about this year's coming incentive programs and opportunity for our provider community. Today we'll be talking about the MPAs, the timeline, the financial concepts, outline the changes between last year and this year. We'll go into some detail around the actual incentive components and deliverables, talk a little bit about the reporting requirements, and we're also introducing a new program that we're pretty excited about. We will outline kind of the concepts and next steps around a new incentive program above and beyond the MPAs. The good news is we have listened and taken your input very seriously. You will notice that we have cut down significantly on the number of deliverables. The focus on performance has increased from last year, and I will tell you that last year's results are coming in from New York State, and our focus on performance is really paying off. That will mean more incentive dollars coming into this region that we can flow to our providers. So we'll get started with the webinar. Again, you'll have time to ask questions. I will stop once after we talk about and present the information for the MPAs. We'll open up both the chat line and the phone line. You can submit questions as I'm speaking. They will queue. And then we will talk about innovation funds and best practice, and you'll be given another opportunity at the end of the webinar to ask additional questions. So we provided and started out with an MPA timeline. All of our provider incentive programs involve governance and committee input and approval. We actually worked through that process through July and into August. We developed the billing templates, which were reflective of the actual deliverables and dollars associated with those deliverables. And we prepared and mailed those in mid-September. So the MPA amendments have been mailed out, and you should have received, someone in your organization, with just a couple of exceptions, should have received your amendments by now. If you cannot track down in your organization who received the amendment, please feel free to reach out to your relationship manager and we will help you track it down. In early October, we plan on opening the additional incentive funds, including the innovation fund applications. And then just a reminder that when you receive your amendments for the MPAs, you have 30 days to object or decide to withdraw from the program, and that date will occur by mid-October. Failure to respond will indicate your acceptance of the program. So the district calendar is always confusing to many of our partners. We have the actual district year, and I think the easiest way to think about that is compare it to an organization's fiscal year. It's kind of when the finances are done and the business. The district year is defined by New York State and actually starts on April 1st and ends on March 30th of the following year. The MPAs are more concentrated on what we refer to as the measurement year, which begins on July 1st and runs through June 30th. It is the services provided during measurement year 5 that are the focus of this year's MPAs. The performance on those services between the timeframes July 1st and June 30th of 2019 will drive our performance reporting, our ultimate results, and also create the incentive dollars that we will flow to providers next year. So what does the funds look like this year? So we have our base MPA deliverables, which all of you have been participating in for the last few years. An amount of funding that we have earmarked to flow to our providers via this mechanism is $15 million. Now, in comparison, the total incentive opportunity for our network partners was 12.5. So this year we're up to 15 million for the MPAs alone. And then we have 3 other programs that are available to our network that offer the opportunity for new funds, in addition to the MPAs that we have sent out to you. The high impact list incentive for 500,000 really represents a maturity in our analytics and our ability to target specific attributed members and concentrate on our performance metrics. We are now at a point that we can produce lists for your practices that include the patients that have a particular gap in care that you will receive additional funding for providing the service and addressing that gap in care. So we'll talk a little bit more about each of these programs later in the presentation. The Best Practice and Innovation Fund, we are allowing 3.5 million. We expect, depending on demand, that this bucket may grow. Again, we'll go into more detail about each of these programs later in the presentation. And for the social determinants of health, I've always recognized that this is a significant driver of many of our issues, particularly unnecessary hospital utilization. So we've earmarked $500,000 to work specifically on social determinants of health. This is intended for use by our community-based organizations. So the total incentive funding this year for our provider partners that we intend to flow out into the community is $19.5 million. That is in contrast to the $12.5 million that we flowed last year in incentive funds. Millennium is very committed to flowing as many dollars to our provider community as we can. Additional financial concepts, we arrived at the awards based on your individual practice's performance. You will not be adversely impacted by Millennium's performance on overall New York State P4P targets. So we have 270,000 attributed members that we are responsible for. New York State sets targets for us around that entire population. If we meet those targets, we earn money. If we don't meet those targets, those dollars go to other PPSs and regions who performed better than we did. So I want to emphasize, though, that all of the dollars that I showed previously are available to our provider network, even if we don't meet one New York State target. Now, if we meet the New York State targets, that simply creates additional funds that we can add to the provider incentives and programs for next year. So how did we determine the allocation of funds by provider type? It was based on the number of deliverables, the complexity of the deliverables, the number of total providers within each category, our return on investment, particularly we want to maximize the pay for performance opportunities, and also our high performance fund opportunity. So for this year, you'll see what the allocation was of the $15 million by provider type. We've also included for comparison and reference the allocations for last year's MPA. In every category, with the exception of maternal and child health, you'll see that the allocations have increased. We also wanted to emphasize that we assign provider types and calculate awards based on their size. So the higher attributed members, the more of the allocation that you are entitled to. So this is simply details on what the parameters are for that. I'm not going to cover it in detail. I will say that there are a few practices whose award and size categories have changed secondary to updated information. If you are one of those organizations, you would have received a letter with your amendment indicating such. So there's a few changes to the MPA documents and amendments that you would have received. In prior years, we had a Exhibit A and an Exhibit C in addition to the billing templates. Those have all been standardized and combined for all provider types. So our new Exhibit A represents an entire scope of work in addition to the award. That is a little different than last year because you receive separate documents in each of those categories. So the billing templates are incorporated now into the contract. Those are the tools that you use to understand what your deliverables are, be able to model what type of money you're entitled to, and they were included in your amendments. So here's what a billing template looks like. Every deliverable and measure is identified. It has a dollar amount. It has the total maximum award that you're entitled to based on your size. And if you belong to an organization that has multiple provider types and multiple services, your billing templates will have multiple tabs plus a summary. So for example, a large integrated hospital system that has hospital-based clinics, acute care, behavioral health, will have multiple billing templates in an Excel document across those tabs. They will receive a billing template for each service area. The billing template includes information like the payment category, the name of the program, the activity that it is expected our providers will implement, as well as a substantiation that will need to be documented or submitted to earn your dollars. So what are some of the components of the incentive? Basically the deliverables. Again, I think everyone will be very pleased. We've significantly decreased the number of deliverables to ensure that your staff, time, and resources can concentrate on the things that have the highest and most positive return for Millennium and therefore for this region. Our focus on performance continues. Last year was our first push into tying majority of your dollars to outcomes-based measures. That trend continues and actually has increased. You'll see that for primary care and acute, the amount that you earn based on performance is between 81 and 90%, and that the amount awarded for engagement and reporting and transformation has decreased somewhat. Again, that is consistent with our focus on performance and helping our region to realize the maximum number of performance dollars available via this program. So I'm briefly just going to cover the types of deliverables. I'm not going to go into a lot of detail and read these slides word for word, but you're going to find that all of these deliverables should be fairly familiar to you. Again, with the exception of one area, which I will call out, we really have not introduced anything new. So workforce reporting will continue in HWF. The submission of your patient rosters for our PCP groups on a quarterly basis will also continue. As our analytics have matured, we have found the rosters from each of your organizations to be completely critical in succeeding in population health management. Patient engagement requirements will also continue. Keep in mind, particularly for patient engagement and workforce, those continue to be New York State requirements, and there are dollars awarded for continuing those efforts. Their blood pressure control, we ask that you continue to be able to identify those patients with high blood pressure control. There's also a performance deliverable around that. It is a high performance measure. High performance simply means that if we are in the top performance in New York State, there are significant additional dollars above and beyond the regular program that we will be entitled to. So for acute, we are asking and we will be awarding dollars for unadjudicated claims. Again, that increases our 360 view for our entire network. In the transformational space, the first category is a deliverable around value-based payment. We're asking that you reach out to your highest volume managed care organization. You have them provide a list of your attributed patients and you reconcile that with your actual practice. That is a critical step in preparing for VBP, and we really feel it takes it to the next level. So again, you'll see blood pressure control throughout all these categories. One of the ways that we can improve our blood pressure control measure and outcomes is the use of CPT Category 2 codes. Your relationship managers will reach out with more information, but bottom line, blood pressure control can only be assessed based on medical record review, and the use of CPT codes in the Category 2 indicates when a patient's blood pressure has been controlled. It's an actual code that will indicate to a reviewer that that has been done. So it increases our compliance with that measure and decreases the need for medical record review and requests that come into your practice. So in the acute arena, we are continuing ED care triage. However, the focus is going to be on the engagement and reporting of PCP visits and follow-up. For acute, ED diversion is a new introduction. It really should not be new to any of the hospitals we've been working with, but we've actually earmarked money that you will receive if you have implemented or newly implement an ED diversion program within your hospital during the MY5 measurement year 5. A new deliverable or opportunity, okay, sorry about that. A new incentive is a hospital utilization work group. We've talked about this with bonus program participants, but we now have the data to actually have meaningful conversation. We've also provided incentive dollars for all of our practices to sit down with the hospitals and brainstorm and work on together and collaboratively decreasing unnecessary hospital utilization, be it ED or for admissions. So the performance measures many times have multiple targets associated with multiple incentives. So achievement of a higher target earns a higher incentive. Each participant can only earn one of the incentives. So below you'll see an example around primary care access for adults. If you improve your access numbers by 5 to 8% when compared to last year, you earn a dollar amount. And then as your compliance increases or you reach our best practice rate of greater than or equal to 89%, you will realize the highest dollar amount. I'd also like to draw to your attention that we have decreased the thresholds, again, in response to some concerns that were addressed by our partners. Last year, you would not earn any money until improvement of at least 10% or greater was realized. Now you can earn money with improvement at the 5% range. And then the better you perform, the greater your improvement, the greater your overall award will be. So we continue our focus for primary care, for preventable ED visits. Last year, we had a focus on target conditions for both avoidable admissions and preventable ED limited to asthma and COPD. This year, we will be monitoring all preventable ED visits and admissions for PQI 90 conditions. Of course, we're going to, and this shouldn't be new to anybody, this is just an expansion of the category that we're going to try to monitor. The 12-month annual visit adherence rate continues, and the blood pressure control with just a few minor changes continues. For acute, again, a focus on hospital utilization, preventable ED visits, PQI 90 admission rate, and reducing the 30-day readmission rate. Again, we have incented the PCPs to come to the table to form collaborative work groups so that as a region, we can work on these together, both from a hospital and a PCP perspective. So the high impact lists that are referenced in your MPAs, as I had kind of alluded to earlier, we are now at a point in our analytics where we can identify our attributed members that have a gap in care. We plan on sending those lists to your practice, and for every gap in care or service that you provide, you will receive $150. So we'll have, for example, we'll send lists to you of people who haven't had a visit in the last 12 months. If you can get them in within the required time frame, that'll be $150 per visit. The same will be true with some screening and lab testing. And you'll simply need to submit documentation showing the services was provided, and we will award those dollars. So I want to, though, point out that not all practices will receive lists. This is really going to vary quarter to quarter. It's going to be dependent on the number of attributed patients associated with the practice and the number of gaps in care. It's also going to be driven by the individual measure. We're going to prioritize measures we are not meeting. For those that we're meeting or exceeding, it just doesn't make sense to spend our time and resources or yours pursuing that as a priority. So the total MY5 allocation for this incentive, PPS-wide, is $500,000. And if we have great success in this category, because this is the one kind of new initiative that will have a direct and positive and immediate impact on our performance measures, we will consider increasing this bucket depending on the success of the program. So there are some changes from DY3 MY4 to the new MY5 MPAs. As I alluded to, we have decreased the number of deliverables. So here is a list of things that are no longer included in your MPA. The focus on health literacy, medical record review best practice, referral of your non-utilizers to our community-based organizations, PAM assessments, SBIRT screenings, major depression management and follow-up, cardiovascular disease management, statins, or some of the medical neighborhood, more transformational or workflow and process, health home linkages, care coordination. I'd like to emphasize that although they are not included in this year's MPA, these activities are still considered best practice, and we're hoping that the work you've already done in that space will continue now that a lot of these programs have been implemented, and they are absolutely critical in the new world and value-based environment. So as I referenced earlier, the monitoring and management of preventable ED use and avoidable admissions is no longer limited to COPD and asthma. Millennium will be providing reports to your practice about your trends around both of these measures. And then I just want to emphasize to the acute care hospitals, it is our intent to allow you to continue to self-report your readmissions. So reporting requirements. Here are the reporting timeframes and the mechanisms and platforms which you will use to submit your numbers. For patient engagement, that will continue to be quarterly via watchdocs. For workforce, that is twice a year through HW apps. For our performance measures, which are quarterly for our PCPs, as well as a physician roster, we are developing a new process. We found watchdocs to be very difficult to manage. There are a lot of errors in the process of uploading, a lot of confusion. Your relationship managers will be reaching out to you about the new process for reporting your numerators, your denominators, some of the things you have in the past. I think you're going to find that it is a much easier and streamlined process. And then other MPA deliverables as applicable will continue to be reported through watchdocs. So patient engagement, again, through watchdocs. I'm not going to spend a lot of time on this. Here's where you would find that. There's also included both an email and a number. If you have any staff that has questions about this, or you have questions and concerns, please either call this number or send us an email, and we'll get back to you very promptly. Workforce reporting, HW apps, Some of you are used to it. Others, if you do need staff development, we'll be glad to help you with that. They're due twice a year, once on October 15th and the second time on April 15th. For performance measures, the new reporting mechanism will be SurveyMonkey. The data is to be entered quarterly. Your designee will receive an email with a link to the survey, and you will simply enter your numerators and denominators within that tool. Acute care, you do not have reportables via SurveyMonkey, but just keep in mind that you will be expected to self-report your readmissions in your PPR. So what time frames is included in the report? We provided that here. This is very similar to the guidance we provided last year. So the MPAs and the service dates began on July 1st. And that report will be due on 10/15/2018. You can see these dates accordingly. Again, I know that we're not going into a lot of the nitty-gritty detail. This is meant to be a high-level overview, but anybody at Millennium, and particularly your relationship managers, are poised and ready and eager to offer their support if there's any questions or concerns that need to be followed up on. In addition to the billing templates, we will be providing the reporting parameters for each of the measures. This is something we released last year. It'll include the reporting timeframes, the applicable coding sets, any of the exclusion criteria, and also what's included in the numerator and denominator. Physician rosters will be due quarterly. Again, we've emphasized the importance. Primary care practices must submit rosters of all their providers within NPI and provide quarterly updates. Millennium, to start this off, is going to provide the most recent roster, and the practice will be asked to confirm, update, delete, or add providers. And details on this process will be provided by relationship managers. So again, we're not looking for new rosters every quarter. We're looking for you to simply review the rosters we have and note any changes. For other MPA deliverables, such things as workflows or process measures, there is a folder out in Watchdocs labeled MPA deliverables, and the relationship managers will provide instructions about what would appropriately be uploaded to this folder. And again, it's the same email, same phone numbers. Feel free to call us if you need any assistance. So at this point, I'm going to open it up for questions around the standard MPAs and templates. Again, I think you can tell from this presentation that we took your concerns very seriously in a few areas. We tried to maximize the dollars we're flowing to the community. We also cut down on the number of deliverables so that your staff time and resources can focus on those that are most important and will have the highest return. And we also lowered some of the thresholds so that you will earn money sooner. Okay, we're going to first take a look at the questions that are being submitted via the chat function. And right now there isn't any.
I have one through email.
Okay, we do have one through email. Do you know when we will define the high impact list?
Deliver.
Oh, deliver?
Sorry.
Okay, no problem.
I'm writing.
You're like a doctor. Kidding. Anyway, we are working on a strategy around high impact lists right now. We are anticipating probably after October 15th. The attribution for New York State just changed, and we are also fine-tuning our affiliation and attribution. So once those exercises are completed, we will start looking at trends practice by practice, which will then help us decide what measures to concentrate on. So I would say probably by November, we will begin to release the high impact list for the measures that we have targeted.
There's no other questions in the chat, so I'm going to go ahead and unmute everybody on the phone. If you're not asking a question, though, please put your phone on mute. Oh, we have one question in the chat. When will we get the Excel file that will be used to capture the deliverable? That is the billing template.
Yes.
We're sending those out either by the end of this week or next week.
So at the latest, we'll have an electronic version of the billing template as well as the reporting parameters to each of you next week.
If there's any other questions, please go ahead.
Hi, Chrstine and Laura. This is Brett from Jericho Road. I was wondering on the best practice and innovation incentive funds, is there guidance around, or is there a little more guidance around those?
So, Brett, right now we opened up, there absolutely will be. There's still, there's about 10 slides we're going to go through right now. I just wanted to make sure there weren't any questions out there regarding these standard MPAs. And if there's not, we're now going to go over and provide a lot more information and detail around both of these programs.
Thank you.
No problem. Okay, I think we're going to go ahead and use the lines again. We'll talk about best practice and innovation. At the end of this part of the presentation, we'll open it up one more time for questions, and that will conclude our webinar once we've addressed all of those. So we're very excited to present additional incentive opportunities. So besides the $15 million that we're flowing through the MPAs, there's an additional $3.5 million, and we're willing to increase that pot if we need to, based on best practice and innovative ideas. So there's a couple differences between the programs. So the first thing I'd like to talk about is the best practice incentive fund. And probably the biggest difference between best practice and innovation is that best practice is a Millennium defined program. We're taking things that are recognized as best practice within the healthcare industry and most impactful on our P4P outcomes and district deliverables. And we are developing best practice incentives around those. It may be limited to a subset of targeted providers. There's pros and cons to that, but the biggest pro of removing some deliverables and best practice out of the MPAs is the fact that, number one, some best practices are just not applicable to groups, or the groups don't really have a large population of patients that would be applicable to. And number two, and probably most important, by targeting providers where this best practice will be most impactful, you'll see that the awards that we can then give you in exchange for implementing these programs are significantly higher than what you've seen in the MPAs in the past. So they should more than adequately cover time, resources, and other expenses to implement these best practices. So examples include such things, but are by no means limited to submission of unadjudicated claims for incorporation into the Cerner Health Intent platform. This will radically enhance population health management. It will be benefit to our entire network because it will give you a more in-depth 360 view of your patient, particularly services that are being received outside of your walls. Another example is participation in the Millennium Population Health Management Pilot Program for chronic disease. For some practices, we have approached them about this program. It focuses on their chronic disease drivers that are creating ED and hospital utilization. Asthma, COPD, diabetes are a few examples. We assess the practice. We talk about things like, appropriate medication prescriptions and usage, talk about spirometry, depending on the chronic disease. In addition, we also offer, if the practice is interested, supplemental resources to work directly with your patients on behalf of your practice. And we call those services enhanced patient services. So when the best practice guide is developed, a description of the program will be sent out to the practices or hospitals that are eligible for these programs, and then you can make a decision whether you would like to participate or not. So again, these are just a few examples, but by no means are we limited to just these programs. So it's our intent to identify and finalize these programs. Obviously, we can't do 50, but we want to identify maybe the top 10 or 15. And then we will notify each of the practices of their opportunity to participate. We are thinking in mid to late October. So that is the best practice funds kind of concept. It's fairly straightforward. It's Millennium defined. You'll be invited to participate, and then your practice can make a decision based on the dollars offered if you would like to participate or not. The innovation incentive funds are a little different. These are very provider-focused and completely provider-led. So what we're looking for are provider-led collaborative partnerships that bring multiple provider types together to develop innovative programs to meet established quality and value-based targets. So innovation funds are driven by you, the programs, the ideas. We're looking for the provider community to bring your best ideas forward. It promotes a population health and value-driven management approach across the full spectrum of care within this region. And it also serves to establish shared performance measures and targets focusing on value and outcome-driven metrics. So more practically, how to apply. There will be an application. This application for funding must be submitted and include a description of the program and detailed information on the impact on the metrics. I'm going to get into the details regarding the specific metrics we're concentrating on in just a moment. Who can apply? The incentive is open to our entire network, but is limited to current MPA safety net partners. So although non-safety net partners and agencies may not submit an application themselves, they may become a secondary party to the program. So for those of you with MPA contracts, if you identify a metric or measure that requires partnership with, let's say, a non-safety net CBO, or even a provider group that's a big driver but isn't currently contracted with Millennium, you may make them a party to the program and the application, and you know, they can be part of this program. Now, you as a safety net provider will have to work out with the secondary party exactly how much of these funds will go to them, and you'll also be responsible for distributing these funds when we give them to you. So that's the only caveat on that. And we hate to make this more complex than it needs to be. Unfortunately, New York State has very strict guidelines on how much money we can flow to safety net versus non-safety net providers. It's actually 95 to 5% variance, and we are already slightly above the 5% we're flowing to non-safety net programs and partners. That's the reason we had to structure it in this manner. But again, feel free to invite other parties to be part of the application. This is all about results. So what is the criteria for funding? All three of the following criteria must be met or the funding request will not be considered. The application establishes a direct link between the program or resources and one or more of required New York State district metrics. Those metrics will be listed on the next slide. The impact on the metric is directly and definitively established, is measurable, and can be reported on a monthly or quarterly basis. The program is expected to have an immediate and direct impact on the metric. Preference will be given to programs or resources that can be implemented in less than 45 days and or prior to January 1st, 2019. Keep in mind that we're already 2 months into the measurement year. In October, we're going to open up this application. So we need to be able to stand these programs up very quickly in order for it to have a meaningful impact on the rest of this measurement year that ends on June 30th, 2019. If all criteria are met, the application will be further evaluated by the Innovation Committee. Decisions will be sent via letter and email within 15 business days of the application submission or following receipt of additional requested information. So we are being very strict this year around it having to be focused around our performance measures. And I brought this up a few times within the presentation. It's because this is our last year to maximize the amount of performance incentive fundings we can bring into this region. Next year, it's our intent to continue the innovation fund, but we will be able to spend a lot of this money on things that either will take longer to mature, to show results, and or may not be as readily proven, but intuitively we know will make a big difference. So I'm sure there are all sorts of ideas going through everybody's mind about great programs and things you've already wanted to do. Please keep in mind that this year's innovation funds are very focused on very rapid cycle impact on the performance measures that I will cover in just a moment, but that the following year we'll be able to kind of expand and allow looser criteria for innovation funds. So something doesn't seem to fit this year, please don't give up hope. It is very likely that it is something that we could consider for next year. So what are the measures that these programs will have to have some tie and direct impact on? The focus is unnecessary hospital utilization. That includes preventable ED visits, avoidable admissions, 30-day readmissions. The behavioral health outcomes and quality measures, they shouldn't be new to anybody. They are the focus of our MPA deliverables too for the last 2 years. It's 7 and 30-day follow-up. It's the diabetic and cardiovascular screening and monitoring. It's the medication adherence for antipsychotics and particularly antidepressants. Medication adherence is something we are very interested in pursuing. It's a high performance measure, and we've struggled. I think everybody, even the MCO, struggles in this space. So we are very open and interested in ideas in this space. We also don't want to forget about the high performance measures. Many of the measures that I just referenced are in the high performance category. A couple other kind of miscellaneous, there is one survey measure around discussion of cessation strategies for tobacco. And then there's also controlling hypertension, which is why it continues to be a focus of the MPAs. Keep in mind that getting into high performance measures in any of these metrics will result in a significant return. Just to give you an example, in MY3, the 7 and 30-day follow-up following behavioral health, we did meet the targets for New York State. And for each of those measures, we earned $500,000 apiece for a total of $1 million. Our performance was high enough to qualify and put us in the high performance fund. That entitled us between the two measures for an additional $3.4 million on top of the regular program. So I can't emphasize enough the importance, particularly in high performance measures, of trying to get into these funds. The return is very significant, and we absolutely, as a PPS, want to maximize those opportunities. As I said before, we are committed to flowing the dollars we earn back into the provider community, and these dollars and these particular buckets are very, very substantial. And thus far, for MY4, the first 6 months, which actually was last year, but the focus of last year's MPA, our bonus program, we are meeting 5 of the 11 high performance targets. So that's great news. And we are also meeting approximately 21 of the 30 claims-based measures. And in comparison to MY3, we only met 7 out of 30. So we are definitely making progress. So just a few additional housekeeping items, as well as additional details on the incentive funds. We really want to provide guidance in this area. If you follow all of this guidance, your programs will be given serious consideration. We just don't want to be inundated with 100 requests, of which 2025 really don't meet the criteria or more. Funds will be targeted for programs where the program or resource is new and or associated with the expansion of an existing program that can only be accomplished by additional investment, and other grants or funding sources do not exist. Funds will not be provided for existing programs or resources that are already in place that will absorb additional duties or work for you to like roll out this program. And it may also not be used for existing day-to-day operational expenses or, you know, plugging gaps in your budget. It has to be spent on the program and purpose that you submitted in your application. You know, other things that wouldn't qualify, you know, to hire someone to manage your MPA deliverables, you know, something like that wouldn't qualify. We're really looking for new and innovative ideas. Programs must target the Medicaid population. However, the program is not required to be limited to Medicaid. So we know when you roll out programs, particularly for our hospitals, you can't really roll out a program and say, oh, you're Medicaid, so you're going to get it, and you're Medicare, and you're not. Certainly not interested in creating that dynamic for you. However, please keep in mind that when you submit your application, all of the numbers around impact and opportunity should be limited to the Medicaid population. Funding requested should be proportional to the number of Medicaid lives impacted. You know, there's certain measures where we only need a few to get into high performance. So cardiovascular screening for those with schizophrenia is a great example of that. 8 or 10 additional LDL tests will get us into high performance with a very high return. So the fact that your program may only target 10 of the patients will still be seriously considered. Contrast that with something like ED diversion, where our target to meet the measure is approximately a reduction of 7,000 patients. If you submit a program that reduces annually a preventable ED visit by 50, it's probably not going to get preferential treatment. So just keep some of those kind of guidelines in your mind when you're thinking about these programs. High impact, rapid cycle. So next steps, just a reminder, your amendment automatically goes into effect 30 days from the mailing date on the envelope. If you have any questions, objections, are considering not participating in the program, that would have to be communicated to us 30 days from the mailing date of your amendment. If you have not received your amendment, again, please reach out to your relationship managers. We'll help you track that down. We are always ready, willing, and able to follow up and provide whatever support your organization may need, be it in the MPA space or helping you prepare or answer questions and concerns for these new incentive programs. Participants in good standing will be eligible for a 10% payment in January 2019. And as every year, compliance documentation must be submitted on an annual basis, and we'll be looking for that in January 2019. One question that I have received that I'd like to put out there is for the best practice and for the innovation funds, 2 points. For those of you that participate in the bonus program, this will take the place of the seed funding concepts that we rolled out last year. You'll be able to still fund resources and programs, but it'll be through the innovation fund, very similar to the seed funding. It's not limited to just bonus partners this year, so everybody contracted in our network has an opportunity. And secondly, I know some people have asked whether payment will be made once the application or the funding is approved, and that definitely can, and in certain circumstances will occur, but it will be assessed on an individual basis. Okay, so that concludes the presentation. We are looking for any of your questions or concerns via the chat function, and once we address those, we will certainly open it up to the folks participating on the phone.
Okay, so we have one question. Can you send us the slides? We are planning to send those out and also to post them on our website later today. And then another question, we have a couple of questions about the Innovation Fund. How many projects will you fund, and how do you determine the amount of funding for each project?
So we have right now a finite amount of funds. It's $3.5 million. So, you know, when those funds run out, we're either done funding projects or we'll have to evaluate putting more money into that fund. And we're more than willing to do that. It will really depend on the circumstances. So I can't really give you an answer on the number of projects because there could be such variation between the cost of each project, okay? So it's really about when do we exhaust the $3.5 million, and are we going to add additional dollars to that this year? And it probably will be very likely. And then what was the next question?
How do you determine the amount of funding?
So the amount of funding will be directly, the funding request will actually come from the provider. So as far as the application, you're going to submit the program, you're going to submit the impact and how it's going to be measured, and you are going to request a specific dollar amount that you feel is necessary to launch this program. And the way that we'll evaluate whether that request for funding is appropriate is based on the impact of the program, you know, the measure and how close we are or how we're performing currently, if it's high performance. So there'll be a lot of factors when it comes into assessing whether what the final dollar amount will be if your application is approved. But the initial request for dollars around this program should be, and there is a spot, will be included in your application. And we may approve it at the full amount if you've done a very good job outlining, you know, what the costs are and things of that nature. Or we may send it back with revisions and say, all right, we're not funding these things, but we'll fund this at this amount.
Okay, another question is, can we all get list of, hold on. Can we all get lists of unassigned members to primary care for the general metrics? I hope I understand that question.
So I think, so I'm assuming the question is about those that may be attributed to your practice that you're not aware of, and or those within our New York State salient data that don't seem to have an MCO assigned PCP. So both of those situations will create an attributed member for us that doesn't seem to have a PCP visit. And we are actually in the midst of evaluating that now. So I think the answer to your question is absolutely yes. But we're still working through exactly what that will look like.
Okay, then another question about the Innovation Fund. Does that mean you are looking at the number of people in the population to determine impact?
So we expect the providers to kind of identify among their attributed membership how many of their attributed members would be impacted by that program and will be touched by the program. So when you submit the application, for instance, if you're a PCP group that has 100 high utilizers that are responsible for 5,000 ED visits a year and 100 avoidable admissions, and you think you can reduce that by 50% for that population, that's the type of information we would look to see in your application. So I know that puts a lot of burden on the practice itself. I will say that Millennium is behind the scenes evaluating each of the P4P metrics and looking at the opportunity not only by metric, but also down to the practice level. So we will also, when we're developing best practice or we're evaluating innovation, we may even reach out and encourage those where we know has the greatest opportunity to come up with an idea to address something very specific in our measures. So I guess the answer is twofold. We'll be dependent on the folks, the providers that are creating these programs to measure their own impact and the number of lives within their purview it will impact. And we at Millennium will also be doing behind the scenes eval metric by metric and identifying practices where there seems to be a lot of opportunity.
Our next question, how quickly do you anticipate being able to evaluate and approve Innovation Fund requests?
So we anticipate that the application process will be open early October, and as soon as we receive legal and compliance sign-off, the clock starts for us. It is our intent to turn around and answer you within 15 business days, either from receipt of the original application, if it includes all of the information that we need, or within 15 days of the request for additional information. So the longest this should ever take is 30 days, but we will try to be much more timely than that.
Okay, next question. Will the request be private so people don't replicate it? Maybe so people don't steal your ideas?
I think, so if it's about stealing ideas, I think I could go two ways with this question, and please feel free to submit a follow-up if neither of my views capture the intent of your question. So I think as programs are approved, we probably will have some notification because, again, we don't want duplicative programs unless it brings in an entirely new population. So for the PCPs, I mean, you have attributed members that you can impact directly that you know are within your purview. So we may approve your program. It doesn't mean we might not also approve a very similar program for another group for their attributed lives if the numbers are high enough. So there may be some duplication, but it'll all be driven on the impact and the number of attributed lives that that particular program can have an impact on. We'd also encourage you, though, if you identify a great idea, reach out to as many of your colleagues and peers as possible so that you all jointly can increase the number of attributed lives and the scope of the impact of this program and jointly submit one application for a program.
Next question, can we get stats on our groups to develop a better proposal, which will give us a better number on proposal?
So I hope my earlier answers somewhat answered that question. We are in the process of evaluating the individual metrics and then breaking that down by practice where there's opportunity. So we will be sharing that information with you at the practice level. We hope to have that information by the beginning of October.
Next question, penalties for failure of implementation of the innovation proposal.
It'll be expected that the funds will be paid back to Millennium.
Okay, those are all the questions that we currently have in the chat queue. So I'm going to go ahead and open up the phone lines. If you have any questions, go ahead and ask it. But if you don't have any questions, please put your phone on mute.
And just to add to Liz's earlier answer about releasing the slides, she did cover this at the beginning of the when we opened the webinar. But we are recording this, so in addition to the slides, she will send you a link where you can access this recorded presentation at any time, either you or your staff. Okay, the phone lines are now open. Are there any other questions? Okay. I really want to thank all of you for joining us. We are very excited about this year's incentive programs, and Millennium stands by ready, willing, and able to support you and create a win-win for all of us. Thank you again. Enjoy your afternoon.